Hello everyone, welcome back to Learn Anesthesia Basics. I'm Dr. Kavya Mita. Today we will be discussing about congenital diaphragmatic hernia. Congenital diaphragmatic hernia is one of the most common neonatal surgical emergencies in the first week of life. Let's discuss a few neonatal emergencies in first week of life and a second week and later. In first week of life, it is congenital diaphragmatic hernia, tracheoesophageal fistula, omphalocele, gastroschisis, intestinal obstruction, and meningomyelocele. In second week and later, it is necrotizing enterocolitis and hernia. So, these are the common neonatal surgical emergencies seen in the first week and second week and later of the neonatal life. Let's come to the topic proper. CDH, congenital diaphragmatic hernia. This is most commonly seen in 1 in 4,000 to 5,000 births. Mortality due to CDH is 40 to 60%, and most commonly it occurs at 10 to 13 weeks of gestational age. So, what is the pathophysiology behind congenital diaphragmatic hernia? This is the main reason is failure of closure of diaphragm. This leads to abdominal contents in the thorax, which causes mass effect leading to lung compression, which prevents normal development of the lung and cardiac malposition. There will be abnormalities or kinking of or obstruction of inferior vena cava. And congenital diaphragmatic hernia is most commonly seen on the left side. Let's see this as a diaphragm. Anterior we have foramen of anterior we have foramen of Morgagni. We have esophageal hiatus, and in the posterolateral part we have foramen of Bostelek. This is in the posterolateral side. 80% of the CDH are from posterolateral foramen. And what happens in lung is lung hypoplasia of ipsilateral lung. This causes smaller bronchi, less bronchial branching, decreased alveolar surface area, and abnormal pulmonary vasculature. Thickened arteriolar smooth muscle extends to the capillary level of alveoli, which causes increased pulmonary arterial pressure, which causes increased pulmonary vascular resistance and pulmonary hypertension. This increased pulmonary arterial pressure causes right to left shunting. All these changes cause postnatal hypoxemia, acidosis, and right heart failure. So, how do we diagnose this condition? It is by prenatal ultrasound and fetal MRI. We have seen the pathophysiology and what happens to the lung and how do we diagnose this condition. Let's see what are the clinical features seen in these babies or neonates. There will be severe respiratory distress, increased anteroposterior diameter of the chest, scaphoid shaped abdomen because all the contents of the abdomen are pushed into the thorax. Apex beat is shifted because of the cardiac malposition. There will be decreased air entry because of lung hypoplasia, and there will be vowel sounds in chest. These are the clinical features seen in congenital diaphragmatic hernia. How do we manage this condition? First, NG tube to decompress the stomach, and second, put the neonate in a semi-recumbent position with hernia side down. The main thing in congenital diaphragmatic hernia is do not mask ventilate these babies. Next, monitor airway pressures because sudden increase in the airway pressures may lead to pneumothorax. Now let's see what are the ventilation strategies we have to follow in these conditions. pH should be maintained more than 7.3, PaCO2 between 45 to 55 millimeters of mercury, peak inspiratory pressures between 25 centimeters of water. If more than this, higher pressures are required, then go with HFOV and ECMO. Pre-ductal saturation should be 85 to 95% and inhaled nitric oxide is used. What is the surgery or what is the incision preferred in this condition? It is trans-abdominal subcostal incision. Now we have seen all the things. Let's come to the topic proper of an anesthesiologist, that is anesthetic challenges. Anesthetic challenges which we face in this condition are hypoxia, hypotension, this is due to distension of stomach, and bowel. Hypoxemia because of primary pulmonary hypoplasia. Hypotension is due to kinking of IVC or major vessels, and primary pulmonary hypertension and right heart failure, decreased cardiac output, so we might need inotrope support. Hypocalcemia may be present because of blood transfusions. There will be sudden hypotension, decreased lung compliance, and increased peak inspiratory pressures. This may cause sudden pneumothorax. So, hypoxia, hypotension, hypoxemia, primary pulmonary hypertension and right heart failure, decreased cardiac output, hypocalcemia, and pneumothorax are the few anesthetic challenges which we face during the management of a baby with congenital diaphragmatic hernia. So, coming to anesthesia proper, how do we intubate or how do we anesthetize this baby? Anesthesia. For opioids, we use fentanyl because of cardiac stability. We avoid nitrous oxide because there will be compromise in the closure of abdomen. Postoperative ventilation so that PaO2 is maintained more than 150 millimeters of mercury and the baby is weaned over 48 to 72 hours. Why the patient should be weaned over 48 to 72 hours or not immediately postoperatively? This is because this is to avoid a phenomenon called honeymoon phenomenon. In this, there will be early smooth course followed by sudden pulmonary vasoconstriction and lethal pulmonary hypertension. So, to avoid this, the patient is ventilated postoperatively and weaned over 42 to 72 hours. That's it for today. Thank you for watching. Please like, share, and subscribe.